Hello, let's get down to business. This is a very important SDL. We've got lupus in here, which is on a whole lot of differentials. It's a tough disease for patients, and you're going to be including it on, again, a lot of differentials. You want to know a whole lot about it. You want to know the diagnostic criteria. We've also got diabetic nephropathy, and how many patients with diabetes are you going to manage over the course of your career? A lot. So you want to understand the pathophysiology of the elevated GFR and damaged kidneys in the case of a diabetic patient. And then we've got some more minor diseases. HSP, Hinox-Schönlein purpura, is one you might see every now and again. Infective endocarditis, understand that that can have some kidney manifestations as well, largely related to thromboses, clots. But largely, this is an SDL about lupus and diabetes. So as we get into lupus, there are a great many different systems of the body affected by lupus potentially, and there are many symptoms that you can see of lupus, and there are many diagnostic criteria. There's like 12 of them that we have for lupus. And so what I think you need to hear is keep your eye on the ball. What's the ball? The pathogenesis. This is an immune complex disorder in which the body is making antibodies against a self-antigen. It's an autoimmunity. So there's usually going to be one of your own proteins that your immune cells will start producing antibodies against because there's a break in tolerance. And that'll create antibodies that bind antigens, and that's a type 3 hypersensitivity. If it happens in the blood, it's a type 2 if it happens on the surface of a cell. And so every single symptom that you're going to see in lupus is directly attributable to a type 3 hypersensitivity or a type 2 if we're talking about anemias or thrombocytopenias. So that's the ball. Watch it, yo, because they will throw some fastballs, some sliders, some curveballs, and changeups right by you if you aren't keeping your mind about you during these questions. We've got a diagnostic criteria for lupus, and you're going to diagnose lupus if any 4 of the 11 criteria are present either serially or simultaneously during any interval of observation. So serially, that means in sequence. So maybe they've got the malar rash and then it goes away, and then maybe they've got an arthritis and that goes away, and then maybe they've got a pericarditis and then that goes away, and then finally maybe they come in and they've got an anemia. And so that would be 4 criteria in sequence, and that would count, that would allow you to establish a diagnosis of SLE, systemic lupus erythematosus, which again is a type 3 hypersensitivity with a little bit of type 2 in there, autoimmunity. This is a very broad disease that rarely presents the same from patient to patient. It's a personalized sort of disease. It can be benign for decades in one patient, and then it can just go extremely downhill in a span of months or years for other patients, depending on the manifestations systemically. It's got a male to female ratio of 1:9. That's a little bit due to estrogen. And it's characterized by multi-system involvement with the presence of certain autoantibodies in the blood. So here's the table, bottom of page 3. Let's run through it. 85% of patients are going to have a skin problem, be it a malar rash, which is a butterfly rash on the face, on the bridges of the nose, and on the cheeks, right below the eyes, or a discoid rash, which is going to be a raised, bumpy rash with proliferation of skin cells underneath, keratotic scaling, or a photosensitivity. That counts as a skin manifestation too, and that's, I was outside for 20 minutes and I got a really bad sunburn. You shouldn't be getting a sunburn after that short amount of a time outside. So that's the skin manifestations. Patients could have oral or nasopharyngeal ulceration. Why are they going to get ulceration? Well, they're going to get an ulceration because there's antibody, antigen, immune complexes depositing in the very small capillary beds of the skin and of the oral mucosa. And so that's what we can attribute these skin problems to as well. They get rash because antigen antibody gets stuck in the skin, and then immune cells follow because they're attracted to the immune complex, which can activate complement as well. So immune cells swarm and they create some erythema, some inflammation. That's the rash. Now, this inflammation can progress to the degree that your skin can start to slough off. Individual cells can start flaking off and peeling off. And that can happen inside your mouth too, hence the oral ulceration. It's all immune-mediated damage. Keep your eye on the ball. Lupus, immune complex disease. Everything has to do with antigens activating, antibodies activating the immune system. So here's a malar rash. You can really see some skin peeling in this lower left one. Notice the distribution that's very characteristic for lupus. What's causing this? Immune complexes get stuck in the skin. Neutrophils love those guys. Neutrophils pop off, macrophages pop off. M1 macrophages, a lot of cytokines, redness and swelling and edema. There you go. That's why you get a skin rash with lupus. If that happens inside the mouth, you get ulcers. Okay, so that's skin stuff. Arthritis. Arthritis is a very, very common symptom in SLE. 90% of patients are going to have some form of arthritis. It tends to be non-erosive and very, very mild, which is going to help you differentiate it from rheumatoid arthritis, which tends to be a real pain and won't go away at all. It's like not really an up and down problem, whereas this lupus arthritis can kind of be there and then gone and then there again and then gone. It goes in flares. It's a flare-up sort of disease, an episodic disease, whereas rheumatoid, I mean, you got rheumatoid arthritis and you tend to have arthritis every day for a long time unless it's well controlled with medications. So usually two peripheral joints. It likes to be the fingers, which is what might get you to order the rheumatoid factor. And if you order rheumatoid, you know that you want to get ANAs at the bare minimum to go with that rheumatoid factor. So be considering some of these lupus-specific antibodies as well whenever you're working up a patient that you're suspecting a potential arthritis in, because things like ANA, but also anti-DNA or anti-Smith are going to help you make that diagnosis if they're there. Serositis, let's talk about that. What are your serous membranes? Well, your viscera, your organs, tend to have two layers on them. They got like two phones, like Kevin Gates, you know, they got a visceral and a parietal pleura. So the visceral pleura is the one that's sitting right on top of the organ, and then you have a little potential space, and then you have the parietal pleura. So you've got that on your heart and lungs. And you're going to get irritation there whenever there's generalized. How do you get inflammation in the pleura? You have circulating immune complexes. Keep your eye on the ball. This is a type 3 hypersensitivity. Everything in lupus is due to the hypersensitivity. You have immune complexes that deposit into the visceral pleura. And then they create inflammation within the visceral pleura that makes it leaky. The capillaries that go into the pleural layer, they get vasodilated and the endothelium spreads apart to allow for the extravasation of blood and proteins. So are you going to see a transitate or an exudate in there? You're going to see an exudate because it's immunologically mediated with IL-1, IL-6, TNF-alpha. Those sorts of things are going to cause an exudate. So you get an exudate of fluid in between the two layers of the pericardium surrounding your heart or the pleura surrounding your lungs. And as you can imagine, your heart's always beating. Your lungs are always going out, in. And so inflammation in the pleura or the pericardium is very, very painful, extremely painful. So don't call this a costochondritis and not think twice about it. Please do not be that doctor. Do a proper workup. When you've got a patient who says, I've got a rash, but you know, my chest has also been hurting me for a long time continuously, not just, acute symptoms, AMI, but like my chest has been hurting me for days, or I've had trouble breathing for days. You ought to be thinking potential pleuritis here, especially again, if they have the rash or the joint pain or the weird blood panel. Renal disease, kind of the centerpiece of this SDL because we are in renal, studying the kidneys right now. You're going to see renal disease in about 60% of SLE patients. And why do you get renal disease? Keep your eye on the ball. Type 3 hypersensitivity. That's all that's going on here, yo. You've got immune complexes. They get stuck in the kidneys and immune cells follow. And then you get a lot of inflammatory cytokines. And capillary endothelium of the glomerulus doesn't like that, and the podocytes don't like that, and your basement membrane doesn't like that. And so you start to get GBM damage leading to a persistent proteinuria, and that's how you're going to catch the renal progression of lupus nephritis. If you don't see proteinuria, or if you don't see any blood cells in the urine, then you know that while they might have lupus, their kidneys are good for the time being. So it's important to continually order urinalysis whenever you are managing one of these patients. Neurologic disorders can be severe, seizures or psychotic episodes, but can also just be generalized headaches, maybe just general malaise, probably problems with sleeping or eating in a consistent manner. Things like that fall under the umbrella of neurologic disorders, and that's a category that's largely at the physician's discretion. Hematology. All patients with SLE have some sort of hematologic disorder. It might not be every single day of their life, but like it's kind of there sometimes. Anemia, leukopenia, lymphopenia, thrombocytopenia. What do all those things have in common? Well, they're different cell types, but there's not enough of them. The penia, that means a lack of or a loss of. So why do you not have these cell types? And let me tell you, keep your eye on the ball, but watch out, because this pitch is a cutter. This is not a fastball. This one's going to move on you. All of the hematologic disorders are type 2 hypersensitivities, And I'm going to put that in blue so that you remember that this is the number one symptom, the only symptom of lupus that is not a type 3 hypersensitivity is the anemia or the lymphopenia or the thrombocytopenia. And that's because you have these cells floating around in your bloodstream, right? Let's call this a platelet, this little blue thing. And so you're going to be making antibodies against a self-antigen, correct? Because that's a breach of tolerance, and that's an autoimmunity. And that's all that lupus is. Don't get caught up in the weeds. Keep your eye on the ball. Lupus is an autoimmunity. So you make these antibodies, right? And so here's our nice little IgG, and it's just going to zoom in on a platelet and attack a platelet and stick to a platelet. Okay, so no harm done, really, correct? I mean, platelet's cool. IgG's not doing anything. Well, no. Maybe that IgG activates complement, and maybe complement is going to bind to the FC region of that IgG and perforate the cell membrane of this platelet or white blood cell or red blood cell. And then that perforation is going to allow ion destabilization and lead to the activation of the caspase-8 extrinsic caspase pathway and the cell will commit apoptosis. So that's one way that the cell can die. Or if complement is not activated on the surface of this cell, there's another way for it to die. When it makes its way around to the spleen or to the liver, one of your two reticuloendothelial organs, then the macrophages in these reticuloendothelial organs that filter your blood, the macrophages are going to see this immunoglobulin bound to the platelet or the circulating erythrocyte, and it'll have IgG just all over it, because the IgG is reacting against something on the surface of this cell. And so when the macrophage sees a cell that's coated with IgG, it phagocytoses it and pulls it straight out of the bloodstream. No more platelet, no more red blood cell that was coated with all that IgG. So that's going to be called an extravascular anemia if it's a red blood cell, or an extravascular thrombocytopenia if we're talking about platelets. Macrophages in the spleen or the liver are going to yank those things out of the blood. They're just going to abduct those boys. So that's the hematology, type 2 hypersensitivity. Now let's talk about criteria 10 and 11. And I want you to pay really good attention to these two criteria. First thing I got to say is that anti-nuclear antibody is so good of a test for lupus that it's its own diagnostic category. So ANA is always going to be a lab that you order. If this is even top five on your differential, get that ANA. What else should we notice here? Well, this will pop up in a little bit, but anti-DNA antibody is very specific for lupus, but it's even more specific for lupus kidney damage. And so anti-DNA, what's that? That means that somewhere in your body, some apoptotic cell, something has gone wrong, and that cell has spilled double-stranded DNA into the extracellular space. That happened first, step one. And then step two, some white blood cell rolled through maybe a B cell or a macrophage, and maybe the macrophage phagocytosed this double-stranded DNA and then presented the double-stranded DNA on an MHC class 1 receptor, or would that be class 2? Class 2. Class 2's extracellular pathogens. So presents it on a class 2 receptor to a B cell, and maybe that B cell starts making antibodies against the double-stranded DNA because it didn't get properly apoptosed, for lack of a better word. So that's how you get double-stranded DNA antibodies. Understand? And you get those, and what that means is again, it's a very sensitive predictor of lupus nephritis, the kidney disease. So then we've also got anti-Smith antibody, and you need to understand that anti-Smith is 100% specific for lupus. So what that means is there are no false positives. If you have anti-Smith antibody in your blood, you have SLE, period. Got it? That's the most specific lupus test. Then we have anti-phospholipid antibodies, and those are highly associated with coagulation and prothrombotic states. Anti-cardiolipin antibodies also are a potential diagnostic criteria. Those are a little bit less important, but they're related to anti-phospholipids. And then finally, something that is just strange is SLE patients are often false positive for treponemal tests. And I think it's going to be due to anti-cardiolipin antibodies. If that doesn't come up in the SDL, I'll try to do a little bit more research on that, figure out what antibody is causing that false positive, and throw it in the comments below. But the implication of that is, well, number one, it can complicate the diagnosis of a UTI. Number two, this is a clever way to see if confirm a suspicion of lupus. Go order a treponemal test. Oh, but the patient doesn't have any bladder symptoms. I don't care. I just need the treponemal test. Because if it's positive and they don't have any bladder symptoms, well, lupus, there you go. Thrombophilic tendency due to antiphospholipid antibodies. But that's the criteria right there. There's a lot of them. They're all due to the same thing except for hematologic disorders, which is a type 2, but all the rest are type 3s, and that's causing all your symptoms in lupus. And you just need 4 of these individual criteria to call it lupus. 2 or 3 out of 4 is going to be probable lupus. And you can go digging, and you should, and you ought go digging for other positive criteria. If your patient's got the malar rash and arthritis and that's it, then you really need to be getting the anti-DNA, the anti-Smith, the anti-cardiolipin, the ANA. Get every antibody in the book for the sake of the patient, you know? So as I brought up, lupus tends to be a episodic kind of flare up. That's the word in my mind, flares. Lupus has flares. You have attacks of lupus. Your symptoms are managed, and then bang, they get worse. And so something that very commonly flares is the skin symptoms because of sun exposure, photophobia, remember. And then other things that can flare are the arthritis or the pleuritis. Maybe that's there for a week or 2. Maybe it goes away. Maybe it comes back. Maybe it goes away. And that's because of immune system regulation. Your immune system's not going full speed all the time. You know, it needs to slow down and put on the brakes sometimes too. And you can't sustain an immune reaction forever. So when it chills down and slows down, then the symptoms kind of go away. And so that's why we can diagnose lupus serially, because the odds that your patient is going to show up and exactly have the perfect malar rash, probably really low odds of that. They probably had the malar rash yesterday and Monday and the Sunday before that, when they were eating it wherever. And but they show up to your office and they don't have the rash. Why? Well, they're not mad. I mean, they can't do that, You can't, like, hey, reproduce your symptoms right now. Patients can't always do that. And so they might have had the arthritis and had the malar rash, and they're sitting in their office telling you about all this, but they don't have the swollen joints right now, and they don't have the chest pain right now, and they don't have the rash right now. So you need to follow up, please follow up with these patients to try and check their symptoms off, and again, get all that lab work to try to make that diagnosis, because it does wax and wane. Autoantibody tests, ANA, is, again, so prevalent that it is its own diagnostic criteria. Almost all patients with SLE are ANA positive at some time. Here are different staining patterns. I think this is boards relevant, but there is not anything about these particularly in this SDL. I don't think you're going to get asked anything about the specific antibodies. You might get hit with the SSA and SSB are against ribonucleoproteins. So what's the antibody directed against? That's a potential question. But again, that's not something I would ask if I were writing 5 questions for this SDL, because half these antibodies tell you exactly what they're targeting. Anti-centromere, what's that an antibody against? Gee, I wonder, like anti-double-stranded DNA, what's that an antibody against? And so I just don't see what sort of question they could ask us about this. Here we go. Here we go. Yes. Bottom of page 5. Antiphospholipid antibodies are the reason why lupus patients might have a false positive syphilis treponemal test. So remember that false positive syphilis test, that's a diagnostic criteria for lupus. So even if you don't have positive antiphospholipid antibodies, they could be sub-threshold for the blood test, but there might be still enough in the blood to give you that false positive syphilis test. So, question. Patient has blah, 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 syphilis test. You take it again in 4 months and it's negative. You do another test and that one's negative too, because we have more than one syphilis test. What antibody is causing it? And it's like anti-dsDNA, anti-centromere, SSA, SSB, antiphospholipid. Answer is antiphospholipid. So, pathogenesis. Now we start talking about symptoms of lupus. Keep your eye on the ball. It's all autoimmunity. There's a self-antigen somewhere, and your immune system sees it and starts making antibodies against it. And that gives you all of the symptoms in lupus. You need to know that there's a big time correlate between HLA types DR2 and DR3. You also want to know that estrogen is positively associated with lupus risk. And that's because estrogen in general is a positive immune regulator. It gets your immune system upregulated. And so if you have more immune cells, period, then you are more reactive potentially to self-antigen just as a function of probability. You're more likely to see an aberrant self-antigen. Sometimes you have a defect in phagocytosis. Again, that clearing apoptotic cells that can allow double-stranded DNA or nuclear DNA into the interstitium and into the blood, and then you start making anti-nuclear antibodies. How do those nuclear antibodies get there? There's a problem with apoptosis, or maybe there's a lot of necrosis. That's unregulated apoptosis. The cell just dies. It doesn't have any control in how it dies. So understand that loss of self-tolerance. This part is talking about how do the antigens get there in the first place. So it could be a phagocytosis defect, could be an apoptosis defect, could be a complement defect. If you have a deficiency in the complement cascade, then you could have a real trouble initiating apoptosis, which is highly dependent upon complement and also perforin granzyme. But if you don't have a T cell in the area, you need that complement to get the cell to kind of start poking holes in itself. So lack of complement impairs removal of apoptotic cells, and those apoptotic cells are certainly a potential source of antigen that can get this type 3 hypersensitivity rolling. Right here in the middle of page 6, this has exam question written all over it to me. These two sentences here. This one sentence, rather. Anti-double-stranded DNA is associated with lupus nephritis. So, easy question. Patient's got lupus. Patient's got kidney disease. They tell you all this. You don't have to make the diagnosis. And then going back and referencing all the different patterns of anti-nuclear antibodies. What antibody do they have? Double-stranded DNA in kidney disease. Antiphospholipid antibodies are associated with a higher risk for thrombosis and fetal loss. That's it right there. That's it right there. They give you a patient with lupus and she clots. She gets a pulmonary embolism. What was the antibody responsible for the PE? Antiphospholipid antibody. We'll talk more about that biochem in a little bit. Anti-Ro Sjogren syndrome A antibody is associated with higher risk for neonatal lupus. So mom has baby, baby's got lupus. What antibody is responsible for that? Anti-Ro SSA. There you go. That's the question right there to me. And then remember that you can get lupus from a variety of drugs, such as hydralazine. What do we use hydralazine to treat? Typically hypertension, especially in pregnancy. We like to combine it with labetalol or some other beta blocker to get blood pressure down, 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 down. And recall that if you have hypertension in pregnancy, it's called preeclampsia. And if you have hypertension plus neurologic manifestations in pregnancy, it's called eclampsia. And that's very bad because that can lead to seizures and potentially comas. Procainamide might also give you a lupus, actually the most common cause of drug-induced lupus. What do we use that for? It's a class 1A antiarrhythmic that's going to work on the supraventricular nodes, ventricular nodes. Only works on the bottom half of the heart. Clinical manifestations of SLE. Here's where we start breaking down the symptoms. Keep your eye on the ball. Every single one of these, except for the anemia, thrombocytopenia, every single one's a type 3 hypersensitivity. The blood dyscrasias are a type 2 hypersensitivity. So kidney disease, lupus nephritis. Why do you get it? Immune complexes in the mesangium, subendothelial at first, but if they're small enough, then they're going to cross the GBM and go to the subepithelial side with subsequent activation of complement. And so remember, what's the antibody associated with lupus nephritis? Anti-double-stranded DNA. From just a few sentences ago, anti-dsDNA, lupus nephritis. Skin disease. Exposure to UV light damages DNA. The patient then produces antibodies to DNA, especially if there's a problem with apoptosis. Immune complexes form against the antigen. Complement's activated. Local inflammatory response ensues. So layers of the skin get edematous and start to separate, and then parts of the skin can start to slough off. So that's malar rash with peeling, and that's oral ulceration on the lips or buccal mucosa, on the gums maybe, the gingiva. Other symptoms. Cell surface antibodies. What's going on there? Well, if it's a cell surface antibody-antigen coupling, that's not a type 3 hypersensitivity. That's a type 2 hypersensitivity. And the examples of this, again, all of your penias, your blood dyscrasias. And this can be IgM or IgG. Both of them are good at activating complement. IgG is better just because it has 5 potential binding sites to IgG's 1. And arterial and venous thrombosis, what's the pathogenesis for the clotting in lupus? Well, there's this anticoagulant protein, beta-2 glycoprotein 1. And beta-2 glycoprotein 1 becomes activated when it binds phospholipid. And so an antibody against beta-2 glycoprotein 1 is going to stop it from binding phospholipid. Let me walk that back. Omit that last sentence. The antibodies against phospholipid. So beta-2 glycoprotein 1 doesn't get activated because of the anti-phospholipid antibodies. You get that? Okay. So you don't have phospholipids because anti-phospholipids. You don't have beta-2 glycoprotein 1. What's that mean? You just clot all over the place because beta-2 glycoprotein 1 is an anticoagulant. So what does this cause? Arterial thrombosis can go to the brain, can go to the kidney, wedge-shaped infarcts, pulmonary thromboembolism, venous thrombosis there, portal thromboembolus coming up from the mesentery, placental infarcts causing miscarriages and fetal loss. All because of that anti-phospholipid antibody, all because of that type 3 hypersensitivity. Keep your eye on the ball. Going into more depth about these symptoms. Blood vessels. You're going to see a vasculitis in lupus. You're going to see different vasculitides in many different organ systems. And when you see them in the skin superficially, let's warm up your memory here. Let's jog it around a little bit. This is a type 3 hypersensitivity. How do you know? Well, it's a small vessel vasculitis. Well, how do you know? Well, it can't be a medium or a large vessel vasculitis. Geez, it's in the skin, you know? And so what's happening? What's causing all these little red petechial spots? You've got immune complexes lodging into capillary walls or maybe going straight through capillaries into skin interstitium, and immune cells follow those immune complexes, and neutrophils and macrophages make cytokines. You get edema, blood swells into the edematous space. Maybe there's a leaky capillary endothelium because of the cytokines. There's a small little petechia. Every single little small dot, small petechial dot, corresponds to where the immune complexes get stuck in the blood. So everywhere you see a dot, there's an immune complex at the middle of that dot that's activating neutrophils and macrophages, and complement is involved as well. So you see a patient, young woman, 20s or 30s, a rash like this and joint pain. What's your next test? Anti-nuclear antibodies. And whenever you see a small vessel vasculitis, that's what it looks like grossly. What do you see under the microscope? You see fibrinoid necrosis, period. Any small vessel vasculitis, if it goes on long enough, will give you a fibrinoid necrosis, because fibrin is clotting factor 1A. And where do you have fibrin? In the blood or in the tissue? You have fibrin in the blood. So let's say inside the green is our capillary lumen normally. That's where all of your fibrin is. You don't have fibrin in the cells of your interstitial space. You know, in whatever tissue you're in, you name it, you don't have fibrin there. It's not outside the bloodstream, it's inside the bloodstream. So please imagine with me that if you start poking holes in the capillary endothelium because immune complexes attract complement and neutrophils, then all of the fibrin inside the bloodstream leaks into the surrounding tissue. So that fibrin doesn't get far. Why does it not get far? Because it polymerizes with itself. It forms a polymer. That means unit of fibrin, 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 fibrin. And that it likes to stick to itself, kind of like how lipids like to stick to themselves. And so fibrin doesn't make it 2 nanometers out of the capillary endothelium before it starts to polymerize. And so that's why you only see fibrinoid necrosis around the circumference of a capillary lumen. It's so easy, yo, so easy. The only thing that could give you a fibrinoid necrosis is something that damages the capillary endothelium. If it's got a tropism for any other tissue type, you're never going to see fibrinoid necrosis. It's only in vasculitides. And the only other thing besides a vasculitis that we know of that's going to do this is a malignant hypertension, in which you're just damaging capillary endothelium by brute force, pressure, hydrostatic pressure. And the shear of sodium diffusing across all those endothelial cells really wears them out, you know, makes them spend up all their ATP to maintain a nice extracellular sodium concentration, which is really hard to do when your extracellular sodium is like 180 or something transiently, you know. So it'll damage endothelium that way. And then again, same concept, fibrin leaks out, stays around the blood vessel. This pretty pink ring is all fibrinoid necrosis. Right there. And this is from an example of eosinophilic granulomatosis polyangiitis, which is why the rest of these, you see so many eosinophils in the surrounding tissue here. Another example of fibrinoid necrosis. You see this, you know for a fact that some sort of vasculitis is occurring. And if it's not a vasculitis, then patient just had a blood pressure of 210 over 150. You know, that's the only other thing that could make this happen. So fibrinoid necrosis, small vessel vasculitis. Same thing here. What's this dark pink material? Fibrin. Why is it dark pink? Because it really takes up eosin. Why does it take up eosin? Because eosin binds to proteins. Is fibrin a protein? Yeah. Okay. So you know what a small vessel vasculitis looks like inside the body? You know what it looks like outside the body. You ever see this? You're thinking type 3 hypersensitivity, period. Okay. What goes on in the kidney? Well, first of all, you see lupus nephritis, you know the patient's going to have an anti-double-stranded DNA titer. You know that's going to be elevated. How does it manifest clinically? Progressively worse degrees of hematuria and proteinuria. So type 1 and type 2 lupus nephritis, you really don't need to know it because why? Type 1 doesn't have a proteinuria. Type 1 doesn't have a hematuria. You're never going to diagnose this because the patient won't complain of anything. Type 2's got a microscopic hematuria, proteinuria. Very rare that you're going to go out of your way to try to catch this unless you're a rheumatologist or something who's ordering these labs on lupus patients on the weekly. What you want to know for boards is class 3 and class 4. The big difference between them is the degree of damage within the glomerular capillaries. In class 3, less than 50% of any given glomerulus is hurt. In class 4, over 50% of total glomerulus are hurt. So that's why we're going to call it focal versus diffuse. Focal means that not all glomeruli are injured. Diffuse means that just about all glomeruli are injured. What's going on here? Mesangial proliferation, endothelial proliferation. The immune complexes deposit. Neutrophils and macrophages generate cytokines. In response to the cytokines, resident cells of the kidney swell, namely the mesangial cells, interstitial cells. So this is going to be a proliferative glomerulonephritis eventually as these cells keep dividing. And you're going to see subendothelial deposits on electron microscopy. And what that means is that they're large deposits that are on the capillary endothelium side of things. Remember that basically you've got your capillary and you've got podocytes on the outside, and then you've got a lumen on the inside. And if the immune deposits are humped or facing towards the inside of the lumen, you know you've got a subendothelial deposit. So find the curvature of the GBM, and that's going to give you the EM diagnosis. Other than that, understand you might see crescents in lupus nephritis, and that would be very bad because that would require a differential with an immunostain, because some other things like pulmonary renal syndrome and good pastures as well can cause crescenteric glomerulonephritis. And then what else could give you crescenteric? Maybe a post-infectious glomerulonephritis, which remember that's going to have subepithelial immune deposits and a history of antecedent infection. What else? Probably a focal segmental glomerulosclerosis as well could give you a crescenteric glomerulonephritis eventually. And finally, lupus. As the damage to the kidney compiles, you start seeing a more and more drastic degree of proteinuria, and it can reach the point of being nephrotic syndrome, which recall is going to be greater than 3.5 grams a day proteinuria. Class 5 is membranous. Class 6 is advanced sclerosing. That's really an expert, kind of an opinion almost, you know, like there is no lab test for it. You have to be a pathologist and make the call. So I don't think they want you to make the call between is this membranous or not? You know, that is not the sort of understanding they expect of a second-year medical student. Skin findings. You get a malar rash. You know that. Sunlight incites or accentuates the erythema, the redness of the rash. Photosensitivity, you know that too. You also know that 85% of SLE patients total are going to have some sort of skin manifestation. And you're also going to understand that they might not walk into your office with the skin manifestation, but they might tell you that it's been occurring, and so you ought to take their word for it, even though they haven't been. That's a little bit of a tricky situation, but you're going to see fluid edema in between layers of the epidermis, and that's largely due to basal layer degeneration and cell death. And remember, your stratum basale is the deepest layer of the epidermis that's right on the basement membrane of the epidermis, in between the epidermis and the dermis. And then the stratum basale is the only layer of the epidermis capable of dividing and replenishing that keratinocyte population that sits superficially. So again, skin sloughing might involve the oral cavity. Why? Keep your eye on the ball. Type 3 hypersensitivity. Here's an immunostain that's showing you immune complex deposition just right on the floor of that epidermis, right on top of the basement membrane along that stratum basale. Joints. There's not much to say that I have to say about this that I haven't said already, other than it's not rheumatoid. And you're going to know that because the joints typically aren't big and blasted out of place. You don't see Bouchard's nodes. You don't see Heberdines, but those are osteoarthritis. It's typically a bilateral small joint arthritis, and large joints won't be involved. Central nervous system. You could have antibodies against nerves or neurons or glial cells. That's rare. What's more common is the small vessel vasculitis. Immune complexes get into the walls of capillaries in the brain. And then if you've got this sort of fibrinoid necrosis in the brain, that's not good. So that's the most common manifestation of neurologic symptoms. What else could give you this in the brain? Quick, make the differential. Make the differential. Hypertension. And if you get hypertension and the lenticulostriate arteries, we're going to call that a lacunar infarct, correct? And there's a name for it. There's a certain name, Charcot-Bouchard microaneurysms. There we go. And you're going to see patients are going to have motor symptoms that just start getting knocked off slowly. Maybe they'll start be all jittery. Maybe they might have some Parkinsonian symptoms because the caudate and putamen run up through and are supplied by those lenticulostriate arteries that branch off the MCA. There's some of the first branches off of it. Pericarditis and pleuritis. Let's run through this again. How do you recognize this? You take your stethoscope, you put it on their chest, and if you hear something that sounds like walking through snow in Thames, then you're going to call it a friction rub. And you'd be right. And what that represents is that there's fluid in the pericardium or pleura. And so how do they get that fluid there? The immune complexes get into the capillaries of the visceral pericardium or pleura, and then those immune complexes attract immune cells that generate cytokines that make the blood vessels of that area leak, and then fluid extravasates due to the leaky endothelium, and that's going to be an exudate, not a transitate. So is it going to have a high or a low protein when you tap it? It's going to have a high protein, because in a transitate, no protein's getting out of the bloodstream, because there's no vascular permeability. There's no leaky endothelium in a transitate. Transitate's purely Starling's forces, hydrostatic and oncotic. Exudate You can have Starling's forces involved. Yeah, they can help push blood out, but largely it's due to leaky endothelium. So you're going to see a proteinaceous fluid when you draw it out. And so you see a patient, young woman, 26, 28, 35, sitting in a hospital bed, and you hear friction rub. That's lupus until you rule it out. So you need all the lab tests for it. You need to get that ANA ASAP. You always start with the worst potential diseases and rule them out, and then try to progress down your differential to the ones that are less threatening. And so lupus, again, is going to be towards the top of the pericarditis differential, up there with infectious etiologies, because of the variable presentation of lupus. You don't know if this patient is going to have just this one episode and then they're fine for years, or you don't know if this patient's got a lupus attack that could be really bad in the short term. So progressing deeper than the pericardium, getting into the heart, lupus can cause non-bacterial thrombotic endocarditis due to the hypercoagulable state imposed by antiphospholipid antibodies. So we are going to type that out and put it right here, and we're going to stick it on this paragraph for you to see. Because remember, the clotting in lupus is caused by antiphospholipid antibodies that bind phospholipids and take them out of the game. And you need those phospholipids to bind to beta-2 something globulin 1, which is an anticoagulant. So you don't have that anticoagulant, you just clot everywhere. Now, those clots can start forming on lesions of the valves of your heart, or on the chordae tendineae, or on the papillary muscles. So you get that. It's called Liebman-Sachs endocarditis. And what's characteristic about this, as opposed to other causes of non-bacterial thrombotic endocarditis, such as, I don't know, medication-induced. What's distinctive about Liebman-Sachs is that you're going to see vegetations on both sides of valve leaflets, not just the top and the bottom. You got them on both sides. So that's what makes Liebman-Sachs, Liebman-Sachs. You see Liebman-Sachs, you think lupus. And obviously, endocarditis, what else do we know about it? Well, the vegetations can break off. They can embolize to particularly the brain or the kidneys. What else do we know about endocarditis? Well, if it's non-infective, it's going to be slower and a more chronic course, but you can still absolutely see some of the valvular dysfunctions, such as MVP, mitral valve prolapse would be probably the first one that comes to my mind. Maybe something like a tricuspid regurgitation, an aortic regurgitation, aortic stenosis maybe, or a mitral stenosis. You know, stenosis as the vegetations grow and impede the opening of that valve. That's not a true stenosis, but it's the same thing. You know, less blood is getting into the ventricle from the atrium because the valve's not opening all the way. So an endocarditis can give you any of the traditional valve lesions that we know very well at this point in time. And if you get a mitral murmur, you're going to hear it at the apex of the heart. And if it's aortic, you're going to hear it top right listening post, second intercostal space next to the sternum. All that good stuff. Spleen. The spleen is a reticuloendothelial organ. The spleen is responsible for filtering blood. And so if there's a lot of antigens, if there's a lot of antibodies in the blood bound to antigens, the spleen's got a lot of work to do. You dig? So follicular hyperplasia in the spleen. Why? Because there's so many antibodies that the phagocytosing macrophages in the spleen just eat them all up, take them to the B cells, and the B cells will figure out what antibody fits that antigen, and then they'll start clonally proliferating to make more of that antibody. And so that's where the hyperplasia comes from. And so if you can get this in a B cell follicle of the spleen, could you see the same thing in a follicle of any old lymph node? Yes, yes, right on. So patients with lupus, a painful lymphadenopathy might be a presenting symptom. It's not a diagnostic criteria, but it can certainly lead you in the right track. And it's going to be a painful lymphadenopathy because any sort of inflammatory process of a lymph node is painful due to the inflammation that's really agitating nerves. And when a lymphadenopathy is painless, that's when we start to worry, because that's when we're thinking and suspecting tumors and other solid masses of the lymph nodes. So it's also going to tend to be generalized. That means it's not just one here, you know, or like one here, because if it were just one big swollen lymph node, you might say, oh, well, okay, you've got a local infection. But if the patient's got a couple supraclavicular, and then maybe they also got periumbilical palpable lymph node, and maybe like a femoral lymph node too, you feel down in that triangle that's a little bit swollen up, then you're like, okay, systemic disease alert. What in the world is in their bloodstream that is getting all of these B cells agitated at the same time? Lupus is on your list. Lungs, chronic interstitial pneumonitis, itis, inflammation. Interstitial, that means has nothing to do with the alveoli. It's in between alveoli that's really taking the damage, because the immune complexes will get through the capillaries of the lungs and deposit into interstitial tissue. And then the lung has lots of resident macrophages, which are going to swarm on that immune complex and pop off on it. It's going to give you a restrictive pattern of disease, which means that it's very tough to get air into the lungs. And it's going to be tougher to get air into the lungs because they won't be able to expand as well, with all of the fibrosis prohibiting alveoli from spreading out apart from one another. The fibrosis will act kind of like a suit of plate mail on an individual alveoli, you know, and like you couldn't blow up a balloon if the balloon was inside a bottle. You could only blow it up as big as the bottle. So the fibrosis is like a bottle here. That's why it's a restrictive pattern. Pulmonary hemorrhage, rare but potentially catastrophic complication of lupus. And on the flip side of that, pulmonary thromboembolism, which is kind of the opposite side of the hemostatic spectrum. But again, remember that antiphospholipid antibody encourages clot formation. It's procoagulative. And so you can get a big old thing up in the pulmonary artery, and very dangerous symptom, can present kind of similarly to the pleuritis if it's a small one, you know, minus the friction rub. That pulmonary hemorrhage, though, that's a grim prognosis, and I would assume that you would see that in patients who have had SLE for a long time, and it just kind of cause of death sort of thing. Not necessarily, oh, I have no clue that I have SLE, but now I have a pulmonary hemorrhage. So hematologic manifestations, blood dyscrasias. Now, keep your eye on the ball, yo. Curveball. This one's a type 2 hypersensitivity. And we know that because it's antigens, IgG, and complement also activating on that IgG FC region. And the complement is going to be perforating red blood cells and white blood cells and platelets. And that's producing a cytopenia, or a drop in the count of those cells total systemically. And if complement's not activated, then maybe the platelet or the red blood cell gets around to the spleen, and those macrophages see the opsonized cell and yank it out of the blood and pop it, bop it, twist it, turn it, pull it, drop it, you know? So type 2 hypersensitivity, you get it, you get it, you get it. So why could you get here you go, synthesis here. How could you get a pulmonary hemorrhage? Severe thrombocytopenia. There we go. There we go. So even though you're procoagulated, you have absolutely no platelets. Absolutely none. And so what kind of clot has a lot of platelets? An arterial or a venous clot? An arterial clot. Those platelets are crucial for arterial clots. So if you get a pulmonary hemorrhage, it's typically going to be a pulmonary arterial hemorrhage, because that's high pressure as opposed to the veins. So you're severely thrombocytopenic, and maybe the patient's also on corticosteroids or methotrexate or something else that is really going to dampen their self-immune system. And so that just compounds things, because thrombocytes come from a blood cell. They come from the megakaryocyte, which is of the myeloid lineage, I want to say. Or is it GCSF? It's one of those CSF, remember, colony stimulating factors. Platelets are just bags of megakaryocytes that they pinch off themselves and throw into the bloodstream. So the less megakaryocytes you have, the less platelets you have. You don't have platelets, you get bleeds, hemorrhages. LE cells, I'm going to show you a picture rather than read that to you. Here's an LE cell or two. They're basophilic. What's that mean? That means they're more purple than they are pink. H and E, H is hematoxylin, basophilic, purple. E is eosin, pink, eosinophilic. So you're going to see this cell whenever you do a joint tap for an arthritis. Maybe a lumbar puncture, suspecting meningitis, or a pericardiocentesis or pleurocentesis, when you're suspecting, when you hear a friction rub and you want to figure out transitate, exudate. Oh, you see these cells too? Because you're going to order a cell smear because you're a great doctor. Yes, you are. And so you're going to get the cell smear and see those cells, and you're going to say, oh, it's lupus. So how do you make the diagnosis of lupus? Well, you need 4 out of 11. If you have 2 or 3, it's probable. If you have 1, it's possible. Recognize that probable is a permissive category that allows you to include things that are not technically diagnostic criteria, such as pneumonitis or Raynaud's, or even just elevated acute phase proteins, ESR, like SED-rate, and what's the one that I'm blanking on? CRP, C-reactive protein. That's an example of an acute phase reactant. So if those are elevated, you know, you can counter it and say probable SLE, but that it doesn't count as a criteria for definite SLE. What I want to end on is, again, this is a highly variable disease. It's a waxing and waning disease. It's there, then it's not. It can kill you, as we've seen with the pulmonary hemorrhage and the crescentic glomerulonephritis and the pericarditis. The pleuritis, those can get bad and out of hand. They can give you conduction deficits. They could create a fluid compression of the heart that could give you a sort of, I don't know if that'd be called a tamponade or not, but that could certainly give you a diastolic dysfunction. The heart would have a hard time filling up with all that fluid around it if it's not managed properly. Could give you a mitral valve prolapse, aortic valve stenosis, or regurgitation. You could get a big drop in cardiac output through one of those different valve problems, and then that could send you into kidney failure, which if you get the cardiac problem combined with the lupus nephritis, well, then that drop in GFR, that pre-renal azotemia by means of the valve problem, might be enough to put your kidneys over the edge and really start getting you that way. So, man, this is a complex disease, but what I want you to do is keep your eye on the ball and understand everything in lupus is a type 3 hypersensitivity, except for the cell dyscrasias, the blood problems, which is a type 2 hypersensitivity. And you got lupus. Let's talk about HSP, Henoch-Schönlein purpura. This is also a type 3 hypersensitivity. It presents in children. It's very similar to IgA nephritis, which is also called Berger disease, but let me tell you how to break it down. HSP is always in kids, just about always in kids. You see an HSP patient on a test, it's going to be a kid. Now, Berger's disease very rarely occurs in kids. Typically, a kid's got a little episode of hematuria, and then nothing happens, and labs are negative. No proteinuria, just a little bit of hematuria. So, go away. Patient comes back 10 years later, 15 years later, and they've got this really bad hematuria, and they're starting to get a proteinuria too, and maybe they're going into nephrotic syndrome, and that's IgA nephropathy. That's Berger's disease. That's not HSP. Berger's disease likes to progress into a crescentic glomerulonephritis. It can really be a nephritic or a nephrotic. You're going to see a progressing degree of proteinuria. And again, likes to be adult patients. I think it's the most common of the glomerular diseases, actually, in terms of straight up numbers, the IgA nephropathy. And that one is going to be due to a defective IgA galactosylated light chain hinge region that's going to keep that IgA held together. And so when you don't have it properly modified, the IgA protein in the Berger's disease, it's less soluble, which is why it gets stuck in the glomerular basement membrane when it tries to get filtered through. So big difference too is I won't say it. I don't want to confuse anybody. So let's read about HSP and get more into that. Berger's, that's in a different SDL. Sorry for the little distraction. HSP is an acute IgA-mediated leukocytoclastic vasculitis. What's that mean? Small vessel endothelial damage mediated by neutrophils, and they pop and spill all of their oxidative proteases, and you see remnants of neutrophils around the periphery of a capillary, leukocytoclastic. Most cases occur in kids aged 2 to 11. The classic patient has a palpable purpura, particularly on the buttocks and hind legs, and they also have a colicky, upset stomach, and possibly an arthritis. So this thing has a classic presentation, yo. Understand HSP, and it's going to be a palpable purpura. Remember that we looked at a purpura, and we said, every time you see one of these, it's a type 3 hypersensitivity. So you see one of these and it's palpable, what that means is that there's really a type 3 hypersensitivity there. There's so much immune complex that it's swelling up. And so that goes alongside with that leukocytoclastic vasculitis. It's the leukocytes follow the immune complex into the wall of the capillary, into the interstitial space, and there's a little swelling there that creates the petechial bump. This thing usually follows a respiratory infection. It can create a nephrotic syndrome, very, very rarely. Renal disease is going to be in 50% of patients, but again, typically that's a microhematuria or a microalbuminuria, and it's self-resolving and it likes to go away on its own, but it can linger and it can stick around too. So HSP can possibly give you a crescenteric glomerulonephritis. I really don't like how it's talked about and presented, because I feel like they're intentionally overlapping it in this SDL with Berger's disease. And I mean, on a test question, again, these things are very, very different. The HSP kid always has the upset stomach or the arthritis or the palpable purpura, and they'll probably give you 2 of those 3, you know, versus Berger's disease. Patient's got hematuria, might be a bad hematuria, and then out of nowhere, patient's got nephrotic syndrome. There's no petechial rashes. I mean, I won't say no, but like it's not a defining thing of Berger's disease. There's no arthritis and there's no colicky GI pain in Berger's. And again, Berger's is typically an adult. Stains for IgA. 2 things stain for IgA on this test. So know the difference between the 2. Renal disease and infective endocarditis. We said that you can get renal wedge-shaped infarcts due to embolization of septic emboli. And again, it can be bacterial or non-bacterial, but this section particularly is talking about bacterial. So you get a bacterial clot in the kidneys. Oh man, that's not cool at all, because then your kidney is going to get infected besides infarcted. So you're going to get some gangrene on that, and gangrene's infection superimposed on necrosis. And besides the clot, you can also get a glomerulonephritis, which has a couple of patterns to it. You can get a crescentic glomerulonephritis as bacterial endocarditis kind of diffuses into the kidneys. And you're going to see some fibrinoid necrosis of the glomerular capillaries. It's going to be fibrinoid because it's going to be a type 3 hypersensitivity, I would assume, because that's the only thing that can really give you fibrinoid necrosis. And it's going to lead to crescents. And anytime you see a crescent, you know that the cells generating the crescent are the epithelial cells around Bowman's capsule. Onca antibodies are present in about 20% of patients with crescentic glomerulonephritis. And if you see onca antibodies, you know it's probably a pauci-immune, rapidly progressive chrystic glomerulonephritis. And that pauci-immune means that you drop an IgG or an IgA stain on there and you don't see anything. It's dark. It's totally dark. So if you don't see anything on immunofluorescence, there's no IgG there. So what's that mean? It's not a type 3 hypersensitivity. That's what I would think. So you could also get a diffuse proliferative glomerulonephritis. And you know that just by looking at that name, you see diffuse. What's that mean? That means if you took a biopsy, most or all glomeruli would be affected. You see proliferative. What does that mean? It means in any given glomerulus that you look at, there's a very high degree of cellularity in there. The cells are multiplying. There's lots of little dotted nuclei in there. So you know what this thing looks like. Now you just need to connect it in your mind to bacterial endocarditis. And as the mesangial cells swell and proliferate in a proliferative glomerulonephritis, they're going to compress capillary lumens, which is gradually going to drop your GFR, because that's a vasoconstriction essentially, and lead to a tissue ischemia of the capillary. There's going to be no crescents or capillary necrosis in a diffuse proliferative glomerulonephritis. I really don't think you're going to get asked about this. I don't think that Dr. Colson or Dr. whoever your path dude is on your campus, I don't think they want to ask you a question about that. I think what they want to ask you, I know what they want to ask you about. It's diabetic nephropathy, yo. Anytime you see diabetes, you're getting a test question about it. I don't care what test. You see diabetes in your slides, you're getting a test question about it. How do we define this? Well, the patient's got to have diabetes. Check. Well, then what else? Well, you're always doing your analysis on your diabetics in regular labs because you understand that diabetes can lead to kidney damage. And you also understand how kidney damage develops in diabetics. First of all, if you have diabetes, you're at a higher risk than normal for having hypertension. That it's kind of a cofactor. Number two, if you have diabetes, you have a constantly high blood sugar. And so sugar, high blood sugar, is the mechanism of damage in diabetes. So keep your eye on the ball. Diabetic anything, high blood sugar. I don't care what it is. How are those cells getting damaged? Anywhere in the body in diabetes. How do nerves get damaged in diabetes? High blood sugar. How's the eye get damaged in diabetes? High blood sugar. How's the kidneys get damaged in diabetes? High blood sugar. There you go. So how does high blood sugar damage cells? Well, it diffuses into a cell, sugar does. And when you have a high concentration of sugar in the blood, then you have a high concentration of sugar in cells. And so sugar starts glycolating proteins. And that's a synonym, that's the correct way to say non-enzymatically glycosylating. And so when you hear that, the correlation that should pop straight to the front of your mind, because you've been in med school for like a year and a half now, yo, is HbA1c. That is the classic example of a non-enzymatically glycosylated or glycolated protein. In that hemoglobin, that's a protein, but it's got a sugar on it. In the case of HbA1c, it's got one little glucose on it at one specific spot. And so that's glycolation. There's no enzyme that puts glucose onto that protein. Glucose just runs into a protein, and every now and then, because glucose has a bunch of alcohol groups on it, it can hit a specific spot on a protein that is trying to pick up a electrophile, which oxygen is. And so maybe oxygen on a glucose abstracts that proton off, and all of a sudden now it can pick up some love, you know? And so oxygen will stick to a protein that way. So glucose gets onto proteins. What happens next? Well, that protein, all of a sudden, maybe it's not ubiquinated properly. So that means you can't get rid of the protein. So if you just have a protein laying around the cell that you can't get rid of, it's functionally useless. But it's not just useless, it's a net loss, because it's just a big old target for reactive oxygen species damage. And so proteins that are glycolated are big old free radical targets. And so all the damage in the diabetic kidneys are due to free radicals secondary to the glycylation of proteins, secondary to high blood glucose. So we just walked it all the way back. That's how you're getting endothelial damage in the capillaries of diabetic patients in the kidneys. So where I want to go next with this is this section called hemodynamic changes. We just said capillaries get damaged, they swell up. You're going to see hyaline arteriolosclerosis. And this is the classic picture of it. It looks kind of similar to fibrinoid necrosis, but it doesn't stain as deeply pink. It's more of a blush pink or a baby pink. And this hyaline arteriolosclerosis is, again, owing to glycylation of proteins. And so the endothelial cell swells as oxidative damage accrues. And when the endothelial cell swells, as you're looking at in the middle of this image, what's happening to the lumen of that capillary? It's getting compressed or vasoconstricted. Understand that. Endothelial damage, vasoconstriction. So the next step, for some reason, the efferent arteriole tends to get hurt by hyaline arteriolosclerosis in the setting of diabetes way more often than the afferent. The efferent preferentially gets hurt. And so you've had renal physiology. What happens if you've got an afferent going into the kidney and an efferent going out, and you clamp down on that efferent because of diabetic damage? What's happening to your GFR? It's going straight up. So that's really bad for your kidneys if you make it last forever, you know? Because if this is diabetic disease and they're not controlled, then this thing just keeps getting worse, more and more constricted. So GFR keeps going up, 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 up. And so you get what's called hyperfiltration damage. And that really hurts the basement membrane, because all of a sudden the hydrostatic force going across that membrane is even higher. And the amount of proteins that are banging against that basement membrane trying to get through is even greater. And so eventually the basement membrane is so stressed it just can't take it anymore. And it starts to crack and split. And so small proteins start to get through the basement membrane when it splits, which is why in diabetics with kidney damage, they will present with an ascending degree of microalbuminuria, a small amount of protein in the urine. Less than 300 milligrams per day typically, nowhere near the 3.5 grams that would make you at the nephrotic cutoff, nowhere near that. It's a smaller degree of proteinuria, microalbuminuria. And so, because this afferent artery is constricted, you know that the afferent artery is constricted, or the efferent, whenever the patient's got this proteinuria, you can infer the basement membrane is damaged. And so you say, holy smokes, this dude's basement membrane is not going to just replace itself. It can't really do that, you know. We need to mitigate the vascular component of this damage by taking stress off the kidney and lowering that GFR. How are we going to do that? Let's start them on an ACE inhibitor, because an ACE inhibitor preferentially vasodilates the efferent arteriole where all of this hyaline arteriolosclerosis is occurring. So that's your treatment for these patients. That plus control your blood sugar and get your A1C down to 6, 6.5, 6 or under, because if you control your diabetes, this arteriolosclerosis will not get any worse, because the only reason you have this hyaline arteriolosclerosis is because of your diabetes. So you need to walk the patient through that and explain that to them so that they understand their kidneys are going to be fine if they hold up their end of the deal. And that also includes hypertensive management, because the only other way you get hyaline arteriolosclerosis besides non-enzymatic glycylation of proteins within capillary endothelium through diabetes is if you have a high hydrostatic pressure mediated by a high blood sodium. That's hurting capillaries just by sheer force. So if the patient controls those chronic diseases, this arteriolosclerosis won't get that much worse. They won't progress to the sort of glomerular nephropathy that you're seeing in these images at the top of page 14. So you're looking at a diabetic glomerulus, and it's got a classic pathognomonic appearance. You see these Christmas tree ornaments or chocolate chips up inside of them. Very distinctive. You call them whatever you want. You know exactly what they are when you're looking at them. They are not any other sort of glomerulonephritis that we've seen. This is an easy visual diagnosis. What you need to keep with you. Number one, in diabetes, glucose causes all the cell damage by generating reactive oxygen species at a higher rate than if you had normal glucose. Number two, that's going to preferentially vasoconstrict the efferent arteriole. Number three, that's going to raise your GFR, which is going to raise your glomerular capillary pressure, which is going to lead to glomerular hypertrophy and hyperfiltration. So, number four, those factors are going to thicken the glomerular basement membrane and injure podocytes. We know that glomerular hypertrophy injures podocytes because they can't stretch and divide to keep up with the proliferating endothelium and mesangium. So that thickened glomerular basement membrane that is eventually going to get some cracks in it leads to, number five, proteinuria, which is a microalbuminuria because it's not a lot of protein in the urine, but it's a little bit. It's diabetic nephropathy. Let's talk about fibrillary glomerulonephritis. Characteristic fibrils on electron microscopy that do not stain with Congo red, so it's not amyloid. The most common pattern is a membranoproliferative glomerulonephritis. So membrano, you see thick membranes, might even be double contoured or tram tracking. You also see proliferation of cells within the glomerulus, and so you see a lot of nuclei, hypercellularity. You could be subnephrotic or totally nephrotic in terms of your proteinuria. And remember, that's going to be over 3.5 grams of protein per day in the urine. You might see hematuria and hypertension. There is nothing special about this disease other than the randomly arranged, straight, non-branching microfibrils in the mesangium and glomerular basement membrane. So you see that there's, again, this is membranoproliferative. This is very clearly, to me, too, membranoproliferative because you've got a lot of space in between cells. That's the membranous part to me. Something is making all these different membranes in between cells super stupid thick. And then proliferative, you've just got a lot of nuclei up in here compared to a normal glomerulus. I dare venture to say that you've got greater than 100 nuclei per glomerulus here. So even though you can't see the fibrils with electron microscopy, you can at least on light microscopy say, this is a membranoproliferative glomerulonephritis. And so then if they give you the characteristic electron microscopy finding 2, you can make the diagnosis of fibrillary GN. Let's talk about immunotactoid glomerulopathy. Man, there is nothing special about this other than that you also see microtubules on electron microscopy in this, and they've got a particular parallel array. This is the point in the SDL at which I say, man, you couldn't just have given me another 2 pages about diabetes and told me something more applicable, you know? This is associated with B cells. You get kidney problems. I mean, there's, it just kind of rubs me the wrong way when, you know, you got like 3 or 4 paragraphs, like 8 sentences total about something. It's like, why did you even include it? Yeah, I don't know. And I don't really care either, because we just learned a lot about diabetic kidney disease. And we just learned a lot about systemic lupus erythematosus, which are the 2 big takeaways from this STL. So I hope that you enjoyed talking about these prominent, prevalent diseases as much as I have. Keep studying hard. Let's go get these capital A's on this test.